Hochner, thank you, Shira, and Hagit Hochner, the director of the IMPH program, as well as faculty. I can see Yehuda and a few others there. So let me introduce, please, our today's topic is artificial intelligence, AI in healthcare opportunities and challenges. And I welcome especially our panelists. Dr. Gabriella Lawrence, an IMPH alumna from 2011, who has taught some of you while she was doing her doctoral work here, is currently a senior director of clinical product and solutioning with Taito Care. Shani Fargun, an MIT Sloan Fellow in their MBA program, joining us from Newport, Rhode Island. She said, as opposed to Cambridge, Massachusetts. And Shani is an AI digital healthcare and patient experience expert. Joanna Braunold, the Director of Content, Marketing, and Communications with Taito Care, also joins us on this panel. And the format is as follows. Gabby will start and introduce herself for the thank you so much for having an alumna here, and very grateful to have our very strong panelists both from Israel and Israeli from studying rather in the United States. Gabby, when she finishes, will give a brief introduction for herself, then we'll introduce both Shani and then Joanna. They will have their presentations. If you have any questions, please put your questions in the chat. Shira, I should also introduce, I need to introduce, I guess, Shira Nanavati is the IMPH Alumni Communications Coordinator and the co-coordinator for sure for these webinars. And Shira will monitor the chat. And then when it comes to the Q&A at 5 o'clock, we hope we will open questions and take questions from the group itself and respond to the questions that you have posted in the chat. So for now, I turn this over to Dr. Gabriella Lawrence to introduce herself and the topic that we are going to discuss today. Thank you, Gabby. Thank you all.
All right, I'm just going to share.
Martin, I see your whiteboard. I don't know that I think that might be a problem.
It's fine. I
Okay.
think if I share,
Sorry.
then
It's just a
That's fine, Martin.
Yeah, sorry.
You're welcome to present at another time. Absolutely. Over to Gabby.
All right, do you all see my screen?
Yes, just fine.
Great.
Thank you.
All right, so I will introduce myself and give you a little bit of background on my journey to where I am today. And I will hopefully not spend much time talking because I think our panelists are really incredibly um, experienced in the field of AI, and they'll have a lot more to say than I do on the topic. But I'll introduce the topic high level. I have had, thankfully, the opportunity to work with AI tools in healthcare, and I think over the last couple years, things have really changed a lot. I think it's a really fascinating journey that AI is taking, and the future is going to be the near future is going to be particularly interesting, and I think healthcare is a fascinating field to be a part of during this era. Um, so just to talk about myself a little bit, you can all call me Gabby, Dr. Gabriella Lawrence, but I was known in this world as Gabby, and you can send me when you send me emails, you can just call me Gabby. I am a former IMPHer, and as you can see in the middle of the screen here, the first half of my career was really spent in the world of the Bronze School and in academia. And I have to say, it was probably one of the funnest periods of my life. Really, I moved to Israel 20 years ago. You can see a little Tel Aviv picture at the top from the US. And when I first got here, I was, in a new country and didn't really know what I wanted to do with myself. I'm the daughter of two physicians, and I knew that I didn't want to go into med school in a new country and a new language. I was newly married, And I sort of had this like crisis of identity and actually went and worked in public relations for a few years. And I did not get the sort of positive feeling that I wanted to get through those years in public relations. I missed the healthcare space too much. Again, being the daughter of two doctors, and I somebody gave me the idea. A former IMPHer said, I just finished this program. It was amazing, and you should try it. It actually took me two times applying before I got in. And I'm so thankful that I did. I then spent the next many years, I went straight from my MPH into my doctorate in epidemiology. And I spent those years as I worked toward my doctorate also teaching epidemiology and research methods with Chagit and with Yehuda. And teaching was really the thrill of my life. I really miss it to this day. Um, and I loved, and you can see this, the pictures here are of what I thought was going to be my last year teaching. But couldn't get enough of it. So I actually, after I left and finished my doctorate, I actually came back a couple more times. But eventually, as much as I love the teaching aspect, and as much as I love doing epidemiological research, I really wanted to get more involved in implementation and innovation. And so I left academia and I went to work for Clalit Innovation. At the time, it was called the Clalit Research Institute. And it was a really nice transition, combination of being able to apply my studies and my skills as an epidemiologist, but begin to think about how we can apply that to innovation and implementation. Clalit is Israel's largest HMO. There's four HMOs. If you remember from your studies, I don't know how long ago each of you were in the program, but I'm sure you learned a little bit about the Israeli healthcare system. And what's really amazing about the Israeli healthcare system is how innovative it is. And so, back in 2002 already, Israel started collecting data, creating electronic medical records. Um, by 2008, those records were fairly strong. And so, by the time I got to Clalit, I was, able to work with about 10 to 20 years of longitudinal data for over 4 million people. And it was an amazing, amazing opportunity to both do research and begin learning. I actually already began learning about machine learning and AI back then. And we'll talk a little bit in a minute about, the history of AI very briefly. And then in addition to being able to do research, begin thinking about how to actually apply interventions and innovation within the Clalit HMO. I was there for, I'd say about 4 years. And I went from there, came back to my love for the Hebrew University and went to work for Ronit Calderon as the deputy director for the National Program for Quality Indicators in Community Healthcare, which is an amazing national program to really ensure that the Kupot and the health system is providing the basics of basic in healthcare to the people of the country. Make sure that the people that if somebody has diabetes, they're getting their A1C measured, and there's some effort going into making sure that A1C is in a controlled range. Making sure people are doing screenings for cancer, and as part of that, I came to that program um, right at the start of COVID. And it was a really fascinating time when, the concept or the emphasis on community healthcare was, I think, really put in question. We had a global pandemic, and people weren't really thinking about cancer screenings and diabetes control. And so it was a really fascinating time to think about our priorities and how to maintain community healthcare priorities over that very challenging period. And during that time, I accidentally met somebody who had recently started an innovation center in Tel Aviv, called, it's now called Elevance Health, but it was at the time called Anthem. And Anthem or Elevance today is one of the largest U.S. health insurance payers in the U.S. They serve uh, over 45 million members, and then they provide services to over, I think, 100 million people. So again, quite a fascinating place to work when it comes to data. The goal of the Innovation Center was actually not really around research at all, though we did have one arm that did some research, but that was really when I transitioned a little bit from public health and epidemiology, maintaining the skills that I learned through all those years and really applying the processes around research methods and how to use data to answer questions and so on and so forth. But really started focusing a lot more on how do we apply innovation in healthcare. As part of that role, I was the clinical director of their Israel Innovation Center. It was really all about bringing innovation from Israel into the US system. We worked with many really fascinating startups. And one of the startups we worked with was TytoCare. And so when Elevance Health decided to close their Israel operations, it was a natural transition where I moved over to TytoCare. I'm not going to tell you too much about what Tyto does. I think they're amazing, but I'll let Joe, who's speaking in a little while, get into more around what TytoCare does. But the general concept is it is bringing the clinic into the home or really enabling um, healthcare, physical exams and healthcare and things that you would normally get in a clinical setting to be done from anywhere. And so it does amazing things for access to care. And I'll let Joe continue down that front. Um, and I've been at TytoCare actually for only 2.5 months now. So, the reason I'm walking you through this journey of mine is, I think, just to, sort of show my experiences in the tech space so that, somebody's talking to you that sort of knows what they're talking about. But it's more to really, give a point of view of, sort of the journeys that I think a lot of the students in the IMPH have taken. They're not one and the same, right? You don't just like go to the IMPH and then you know exactly what you're going to do next and everyone follows the same path. It's really, really varied. And as you can see from my journey, it's been really balancing both the academic world and the innovation and the tech world at the same time. So that's just a little intro to who I am. And the topic we're talking about today, AI. So I actually, for the fun of it, decided rather than, just looking up on Google or in the dictionary, what is AI and how has it transitioned over the past many years, I actually went and asked ChatGPT to do it for me, apropos to what we're talking about. And so AI it's not a new concept, right? This word artificial intelligence, and I apologize to the person who coined it. I forgot what their name is, so my apologies. But this is something that's been around, the concept and the ability to use machines and computers to mimic humans, is a concept that's been around for a long time, probably even earlier than 1956, but that's when the term was coined. And in 1956, the concept was really about mimicking human reasoning, trying to, do things like look at things and then respond to them the way that a human maybe would respond to them. So logical thinking, if you gave it a puzzle, it could probably do the puzzle. And it's really, as we all know, it's really changing. And I think for us, it feels like over the last few years, it's like changed exponentially. And I think it has. I think the work progressing to where we are today has been going on for quite a while. It's just now accessible to all of us to experience it and feel it. But today it's really about, replicating human cognition and actually doing things sometimes even differently than a human would do. Um, and so just going through a few general capabilities when we talk about AI, um, from the very basic of just perception, understanding an image, speech, text, um, to really being able to learn from data, learn from uh, the inputs that it's given. So that's things like machine learning, predictive modeling, which we do a lot of in healthcare, reasoning, actually making decisions, even when there might be uncertain circumstances, and then actually being able to interact with human beings, chatbots, summaries, translations, not just understanding the inputs and sort of spitting it back, but really understanding it, trying to understand emotion and interacting with humans in a way that humans want to be interacted with. And then at the far end is also really autonomy, right? So like the concept of like an autonomous vehicle, like something that a machine being able to actually make decisions and carry them out without necessarily having a human in the loop the entire time. And again, Shani and Joe will do a better job diving deeper. Shani will give you a really deep dive overview into AI momentarily. Uh, Okay, so healthcare. Why do we want to use AI in healthcare and what can it be used for? And so here I just have a few examples of ways that AI can be useful in healthcare, ways that it's already being used today. And I think in each of these, we're going to see huge changes over the next couple of years. But I think in healthcare, healthcare is a field that complex decision making, there's so much research that goes into, how do we know that something works? How do we know that it doesn't work? There's a lot of administrative tasks in healthcare as well. And so there's really, I think it's an ideal space for applying AI in many, many ways. It's also a scary space. It's also a space in which people's lives are at stake. Uh, the decisions made have major implications. And so it's a space that I think is going to require a lot of time and patience. Um, and as much as we want to move fast and stay, keep up with the progression of AI in the general world, I think that will also still really require, you can think about it as a babysitter, or you can think about it, but it will require human attention, and not just a babysitter, but really, I think, expert attention for a long time, both to build the trust among the users, but also because we're dealing with something that is so serious, human health, human lives. That being said, I think that there's a lot of space that AI can already have major implications for healthcare, ranging from things like improving efficiency. So again, there's tons of administrative tasks, uh, note taking, really electronic health records, really all of the stuff, phone calls that are done, conversations that need to be written out, all of that stuff around administrative tasks and efficiency, hospital efficiency, um, health insurance efficiency. Those things can really have, they're already prime and like ready to go for AI intervention. But I think even things like clinical decision support, I think again to start, we should look at it as support. It's not a replacement. It's not saying this is the clinical decision, but we can get to clinical decisions so much faster using AI. So when I think about like a doctor, right, the patient, and I often actually describe the difference between public health, right, like in epidemiology, when we do research in a population of people versus an individual, I think kind of similarly with AI, you sit in a room with a patient and you are the physician trying to make a decision. You're making that decision based on all the data that you have in your brain, your education, all the patients you've seen before this patient, the context, the other things going on in the world. All the data that you have as an individual goes into making that decision for the patient sitting in front of you. If you think about the concept of AI, it's taking all of that and multiplying it by, I don't know, a gazillion. It's being able to make decisions based not just on the data that you have in your brain as the physician, but being able to make those decisions based on the data that's in everyone else's brains as well, which is pretty incredible. So there's clinical decision support, enhancing access to care, which Joe will talk about, augmenting our workforce. So again, I think also this is something that will come up in some of the talks today, but really making our workforce larger without necessarily having more human beings in the loop. And then, of course, there's the research and drug discovery world. And this is just examples. There's much more that we can do with AI in healthcare. But all of that requires data. And it's really, at the end of the day, it's really all about the data that goes into the models that really enable us to do these things. And that data spans a million and one things. You have data that comes from, medical claims records. You have imaging. You have genomic data, electronic health records, social determinants of health, all of the epidemiology that's out there, all the research that's been done in the past, current epidemiological surveillance around epidemics, pandemics, so on, the environmental factors. And of course, there's also now social media and web data, which, I'm sure there's a lot of different thoughts on how that should be used towards AI as well. And so we have a ton of data at our fingertips, and all of that data is what feeds into making AI as amazing as it is. But what we really need to keep in mind is that um, the models are only as good as the data that goes into it. And so, the same way I think in lesson one of Epi 101 with Yehuda, we learned garbage in, garbage out. It's the same thing here. Now, I think our models today they're not making, the AI models that are out there and the things that people are doing in healthcare are incredible. So it's not that garbage is going in. It's amazing data that's going in. We've got great data in the world. But that there's still holes and there are still things missing. And I think it's on the sort of the onus of everyone on this webinar today, as you proceed in your careers, and you continue to contribute to the worlds of healthcare, is to think about where the gaps are and how you can contribute to filling those gaps. Because what ultimately happens when you have gaps, and when I talk about gaps, I mean there may be an entire region or country or city or ethnicity whose data is not represented well enough in the models that are out there. And so what ends up happening is you have models that lack validity and lack generalizability. And so it's the most amazing model in the world and it has amazing potential. But when we now apply it to a different group of people, it's not going to be valid anymore because the data that went in was not representative of that group of people. We get into issues of equity and bias. And I'm putting these terms out there, not, to be negative, because I think we have a wealth of data and the AI that's happening today, and some of the examples you'll hear about are quite incredible. But it's the responsibility of everyone working in this field and working in healthcare in general to make sure that we continue to add to that data because without having a complete view and ending up in situations where again you have gaps from particular groups, whether that be again ethnic groups, females versus males, countries that don't have the same infrastructure, or don't have electronic medical records, or places where it's difficult to build the models or apply them. You get into questions around equity and bias. And these models can be biased. If the data feeding in is not representative, the model at the end of the day will be biased. And so I just want to put these terms out there so everyone keeps them in mind. Um, and I think the most important term, and then I will leave us with this and let Shani speak, but I will introduce her in a moment. The most important word is humanity. At the end of the day, we talk about data, even when we do our epi research, sometimes we forget that every data point is a human being behind that data point. It's not a number, it's a person. It's not just that the data is a person, it's also that the benefit of the model, the exciting possibilities of that model will impact humans and people. And it needs to be able to meet the needs of humanity, but also sort of embed humanity in all of the work from the get-go. And I would say that really like spans whether you're doing just some research, a study, or you're doing machine learning, or you're trying to create a large language model, or anything in between. It's humanity has to be at the center, and remembering that it's human beings. We are all people, and the work that goes into AI is based on human beings, and the work that comes out of AI will impact human beings. And with that, that was my just very high level introduction to the topic. So I'm going to introduce Shani. And as Maureen mentioned, I'll stop sharing for a second. So Shani is currently at a Sloan Fellow, getting her EMBA at MIT. Both speakers today are near and dear to my heart. They are current or former colleagues of mine and people that I really truly consider friends and incredibly talented human beings in their own right. I worked with Shani when we were together at Elevance Health. Again, Anthem, Blue Cross Blue Shield, if any of these words ring a bell to you. And we did a lot of innovation work and were involved in AI work together at Elevance. And she went on to work at two other companies, Site Diagnostics, um, and then she went to MIT. Sorry, I'm messing that up. But anyway, Shani's awesome, and I'm gonna let her take over from here. And thank you all.
Thank you, Gabby, for
Thank you,
this
Gabby.
wonderful intro and kicking us off for you know the field of AI in healthcare. Let me quickly share my screen here. Um, Go into presentation mode here. Okay, can you all see my screen?
Perfect. Thank you.
Great. So today we are going to talk about the hype, hope, and the human touch in the vertical of AI in healthcare. Um, I would like to start with these numbers that nearly 8,000 Americans basically are harmed or die each year from diagnostic errors. That's basically 2,000 each day. This is the most devastating and overlooked problem in healthcare today. And we see in healthcare systems that they are stretched very thin and there's a lot of burnout. And AI is stepping in to help this type of problems. But what I would like to focus on today is that not all AI is created equal. And we're going to jump into some of the technicalities of AI, but also some of the applications. A little bit about myself. So, as Gabby mentioned, right now I'm doing a mid-career MBA at MIT. I've been in the application side of healthcare my entire career, so spent over a decade in product management roles. And me and Gabby started doing AI way before it was sexy. I would say like 5 years ago. And then also, what I've been doing here is talking to a lot of professors at MIT, and Boston is really a great ecosystem to be in. There are a lot of meetups, a lot of innovation happening, and also jumping back and forth to New York to attend some of the digital healthcare and AI conferences. And I've spoken to over 160 people this year to deeply research the vertical of AI in healthcare. I'm also curating a weekly newsletter called Blue. This is basically what has been going on this week in healthcare, but also some of the talks that we've been like attending at MIT, which I think brings a lot of insights about the philosophical topics that are being discussed. And a fun fact, I am also doing aerial acrobatics and flying trapeze, but this is just on the side. Yeah, so I would like to start with today's agenda. We don't have a lot of time and we have a lot of grounds to cover. We're going to talk about what is and what isn't AI through the buzzwords. What are we actually talking about? We're going to talk a little bit about some use cases in healthcare. We are going to talk about a framework that I've seen here that is being used to distinguish between the snake oil AI and a breakthrough AI, which I think is extremely interesting. We're going to talk about humans and AI and how to collaborate from some of the research here. This is something that Gabby mentioned very briefly, and we're going to have hopefully like a deep dive. We're going to talk about the risks and ethics and what is the road ahead in AI and predicting the future, which is a very difficult task. And I think with that, we can start by talking about what is AI. So AI is an umbrella term to describe a couple of terms that are related to AI. The first one being predictive modeling, which is basically linear regression on steroids. Some examples could be predicting hospital readmissions. And this has been around for a while now. This is scoring system tools and hospital triage. Then we have the generative AI. The most well-known example is obviously ChatGPT. And these are systems that generate new content. And then lastly, we have the most hyped buzzword right now, which is agentic AI. These are systems that take single action or a single task and combine reasoning, real-time analysis, and memory. Some example could be like autonomous ambient scribes for physicians and workflows and chatbots. So these are more focused. So think about like AI in the generative term, but designated for a specific task. And these are systems that currently are being developed with different data companies that provide infrastructure for companies to develop their own agentic AI. So nearly 80% of US healthcare systems and organizations are already using AI in technologies, most commonly used to improve efficiency of the hospital. So it's mostly admin work, documentation, workflows, decision-making with data analysis. These are still usually with human in the loop. Research for drug discovery, risk management, which clinical trial I should look into next, and then the clinical data. All of these are already using AI currently. And then data collaboration and analysis for predictive modeling and healthcare data to uncover trends. And I would say the one that is just right now going into play is the patient access and experience. So virtual health consultations, wearable device, and ambient listening of AI, medication management, and health apps. These are something that have been developed in the past 5 or 6 years, but right now are more hyped and are going more and more into play. So the use cases that we are seeing across the healthcare, I divided it into two categories, two buckets. One is the ones that are working really well and are already integrated in healthcare systems right now. And then we have the work in progress use cases. So let's start by talking about diagnostics. So medical imaging has been around for a very long time, and we see that radiology and pathology, lab interpretation, and early detection with companies like AI Doc and Path AI. These are companies that are already integrated in healthcare systems. And we see that here the narrow AI works best for a specific task. FDA got a lot of traction there, and these solutions are already approved. There is proven value in that, in the savings. Having said that, there is always a human in the loop there that monitors these systems. But when we look at these systems, we see that the AI has a specific task it needs to perform, and this is where AI shines best. The second thing is admin and ops. By the way, I put like star ranking for each one of them to understand like the type of, solutions and their impact in the healthcare world. We see that in the admin and ops, when we're talking about claims, automation, we see that we have the workflow optimization like Nabala and Abridge. Big ROI there, and we see that a lot of healthcare systems are incorporating that. And this is adopted really quickly across hospitals. We still see a downside, that is the costs of these systems are pretty high. So only robust healthcare systems and hospitals can afford to use the systems and to show the major ROI. But we're talking about if we're talking about primary care physicians, which is like 50% of the primary care across the United States, these are still very small use cases in order to incorporate these systems. And these solutions, as the technology evolves, will reduce the price and will come in play more and more. The third thing that we see here, and I think one of the use cases that are more interesting, is mental health care or behavioral. We see Gen AI therapy, we see chatbot companions, we see companies like Ilios Health that are more on the automation of the note-taking, and the CROs, which are the health questionnaires that are escorting these patients throughout their journey. We see that there is a trust, ethics, and some other issues there, but we see that these solutions are very focused and for that specific vertical. It's still early to see a lot of impact in that field, but we see that these solutions and technologies are coming into play. Then the second bucket across the use cases that we see are the work in progress, so to speak. So in drug discovery, in pharma companies, and just recently I had attended Sanofi portfolio management and clinical trial talk at MIT, Amita. And we see that for the generation of new proteins and molecules, the trial prediction, the end-to-end AI drug pipelines, we see a lot of companies in that field, even from Google, Isomorphic Labs. There is mixed results. So companies that are promising the entire end-to-end drug discovery solution, these are still hyped because the clinical trials and the lab experiments are still with the human in the loop. But we see that for some of these phases, like risk management and decision trees for clinical trials, and scanning through clinical trial data very fast, these are where we see AI making a lot of impact. In the patient experience field, these are still early, I would say, also in terms of cost savings and the economics of healthcare. But we see that we have voice agents, symptom checkers, self-service tools like Amazon Health AI, K-Health. These are some of the companies that have been around for a while now, but have still yet to found the sweet spot of managing cost savings and complex solutions, but also honing in the user journey and the patient experience itself. So these are very nice in theory, but when it comes to play, most patients that are high cost are less likely to engage with these tools. And so the tech savviness of people comes into play very much in this field. And then we have the field of MCP, which is a combination of, it's an AI term that is used for several things, but mainly think about AI that combines voice, emotion, video, biometrics, a lot of different inputs that are combined together into have a frontier that allows the AI to take several inputs and just generate one output. The tech is still there, it is still developing, and it's still niche, but we would see more and more of that in the recent years. We see companies like Anthropic and OpenAI working very rigorously on developing these models. And I think that in that field, it's still early to say if this combination of all of these inputs will generate impact, but we see that it's very hyped right now, and a lot of companies are going into that field. So having said all of that with the use cases, I would like to propose a framework that I've seen from a Princeton professor to discover the landscape of what is AI snake oil and what are the harms based off of this metrics that I'm showing you on the screen. So on one side, we have benign and harmful, which is used to describe if the AI potential could be harmful moving forward. And then we have the axis of works, hype, or AI snake oil, which is AI that just doesn't work at all and has no proven result. So on the bottom left quadrant, we see where AI shines right now, which is autocomplete, ChatGPT, code generation, image generation. This is where AI for these specific tasks is working very well. And then we have the harmful but AI that works, like face recognition for mass surveillance, which is more harmful, but is still something that a technology that was proven. And then on the top right quadrant, we have just AI that doesn't have any proven result and could be very harmful, like cheating detection, which is not proven at all in video interviews. We'll see one example. And then criminal risk prediction, which is extremely biased to predict if somebody is going to commit a crime later on. And we see that these solutions could be very dangerous used with different systems. So just one quick example that I wanted to give you is this job interview tool that is designated to give you results about the traits of a person. And so there is a site called Objective or Biased that is just teasing and testing these tools. So for example, one of these tests were to provide an image of someone videotaped with a bookshelf behind it and without. And we see that the AI model predicts something completely different about their personality traits. They did exactly the same with glasses on and glasses off. And we see again that the AI provides just different results, which is kind of hilarious. So these AI hallucinations and is just on that top right quadrant of AI snake oil, and we should be very aware on that type of solutions that are promising to do something that they're not really anywhere close in doing right now. So with that, I would like to go to the second phase of our lecture, which will be like a little bit shorter. We're going to talk about the risks, the ethics, and the road ahead, the humans and AI together, and then what's next, and what we see that a lot of predictions for AI tools see for the next 10 and 15 years. So a question for you guys, and feel free to kind of jump in without muting. What fraction of AI algorithms are biased right now? Just one person to provide an answer. Go ahead.
Speak up. Anyone?
Anyone?
20.
40%. B, 50%. Okay. Anyone else?
20.
20%. Okay. So this is the intuition that people usually have. However, 100% of AI algorithms today are biased. And the reason for that is very simple. Data is biased. AI learns from historical data, and real world data reflects existing inequalities, omissions, and systemic patterns. For example, very simple example, only 41% of participants in drug trials are women, okay, versus 50% in the population. We see that in many patterns because the data reflects human decisions, okay? The historical data that the AI is trained on. And these are deployed before we can see like FDA regulatory approvals. And sometimes there are black box models that are not transparent about the reasoning and the data behind it. And then the last question is who's responsible when AI makes a call? Is it the developer, the provider? Is it the healthcare system? So clear framework needs to be developed right now. But we know that 100% of the AI algorithms are biased because the data is biased. As much as we want to make the data clean and unbiased as possible, this is always the case. So the point here is not to eliminate all the bias, it's just to recognize it and work with it and manage it. So for example, some of the solutions that I've seen is fairness-aware training for doctors, and then bias audits, inclusive data sourcing, and these are crucial to build responsible healthcare AI systems. And not all AI is created equal, as we alerted in the beginning of this talk. So one example that I've seen is to add good friction to the system. A lot of products, and I've been a product manager for the past 10 years, say that we need to make systems that are frictionless. However, when we're using AI, adding good friction to the system is something that can be very beneficial. One of the examples is Sepsis Watch at Duke University. So they developed a tool to monitor and to screen for sepsis. However, as we all know, sepsis is very hard to predict and to monitor and to flag out. And so the system that they did adds intentional friction to the system, which alerts a trained nurse that reviews the case and then communicates with the doctor. This step, as I said, is intentional. This good friction adds transparency, reasoning, and then a verification of a human in the loop. This speed bump that products can enter into their system is just enough to add trust with the AI system that explains the reasoning, but also ensure the clinical judgment and prevent over-reliance on automation, which is some of the things that Gabby talked about in the previous talk. So one of the things that I wanted to kind of mention as an anecdote is AI first sounds great until you ask who is second, right? So collaboration of AI and humans is something that is extensively researched at MIT right now. And I've been very fortunate to be, part of the program this year because we've seen that research shows us that AI is a tool, but humanity is the point. Equity must be built, and we see that humans are still the accountable party, not the AI algorithms. No matter how smart the model is, the responsibility is still with the humans who uses it. And I think the framing is not about replacing humans with AI is providing humans with the tools to work collaboratively together. And the synergy of these two together is much higher than each one of these separately. We've seen that, for example, one of the use cases that were very interesting is the note scribing, right? So what humans can do right now is to focus on the human interaction and not writing notes in front of the patient. So these tools allow humans to focus on other tasks and to focus on being more present and attentive. And then if we're talking about the different use cases of AI being used in other systems, it allows humans to have superpowers and to focus on other stuff. It's like a junior assistant that provides you with the tools to focus on the tasks that really matter, like the patient and doctor interaction. So this use case I would say is a really good example of, the conversation that AI brings into the system when clinicians and patients interact, and putting that junior assistant on the side to scribe the notes. It's the assistant that we all wanted to have, I would say, at some point of our lives. Having said that, we have some guardrails that we need to implement when we're talking about AI systems. These are frameworks that enhance the safety, reliability, and control in AI generated responses. So one is verifications, which is automated reasoning validation to check the logical accuracy. And some of the system right now are also transparent with the logic that they provide. For example, Claude and other systems that explain the reasoning behind the responses. The AI model's ability to logically generate accurate outputs and reduce hallucinations. There are also RAGs, which I will not get into right now. It's a technical term to just basically say that AI is checking real time the reasoning of the model. And then filters to block, content violations. And these are guardrails that are being used right now. And you should basically look into, if you're looking into getting AI systems in place for some of the healthcare systems. And the last thing I want to talk about, that, like I said, the future is really hard to predict. And so AI systems that predict the future are at best, just speculation. But based off of all the predictions, I would say that in 2025 is going to be the year of, the rise of AI agent networks, which have been proven very effective. In the next 5 years, we will see more and more of personalized and predictive care. For example, wearables and automated flags for personalized care. In 2035, we will see more of clinical decision making using AI. For example, one of the states, like on a federal level, they issued the bill to allow algorithms to prescribe medications for simple medications that are being used. And then for 2040, we will see more and more autonomous decision making in biology. And this will drive the edge of the science more and more. I would like to just close with 4 key takeaways from the entire 20 minutes that we've spent discussing about AI in healthcare. First is that AI amplifies, it doesn't replace humans. Humans are still the focus and are the main liable of the decision making in AI. Bias is everywhere. I found this photo generated with AI very funny, like the number of fingers that are still in the picture. Generated by AI. Snake oil still sells, and you need to use some framework in order to identify which solutions are hyped and which solutions are really helpful. And then the humans and AI together are in a synergy better than either alone. So I will say that the future holds a lot of promise. And humans like us will probably be the ones driving this innovation in the future. I really invite you to connect with me either on LinkedIn or, as part of this talk. And we will have a couple of minutes later to have the panel with Q&A. But I would love to hear any insights and thoughts and use cases that are interesting in AI later. Thank you. With that, I would transition to Gabby, who will introduce our next speaker.
Thanks, Shani. That was amazing. Really, I think gave a really, really good overview to everyone. And as Shani said, definitely reach out to her if you have more questions. She's very, very knowledgeable in this space. With that, I want to transition over to Joe Brownald, who's going to talk about the use of AI and technology in rural healthcare and creating more equitable care using AI. So while we, talked a lot about the biases and we should continue to keep those in mind, I think there's also a lot of promise. Joe is a current colleague of mine. She's the director of content marketing at TytoCare. And without further ado, Joe.
Thank you so much. It's a pleasure to be here. Thank you for inviting me, and thank you to everyone for joining. I'm going to share my screen. And whilst that's coming up, just a few words about myself. As Gabby mentioned, I lead content and communications at TytoCare. Although this is actually my first role in the healthcare space, I am married to a doctor, which means I live vicariously through him in positive and negative as that comes along. And I have about 15 years experience in marketing, like I mentioned, not in the healthcare space. But what's been fantastic, I've been at TytoCare for nearly 4 years now, and it's really been fantastic for me to learn so much very quickly, being thrown in at the deep end somewhat. And really kind of take the skill set that I've built up over years working at startups, working at corporates, and bring that to the healthcare field that we're obviously working at TytoCare. So I'm going to speak today about how AI can help bring better care to rural areas. Before I dive into that, I want to just try and move to the next slide, which is apparently more difficult than I had thought. I want to just show you a quick video just to kind of show you the vision of TytoCare. So I'm just gonna hopefully you'll be able to hear it. If there's no sound, someone shout.
It's fine, Joanna. Or it was. Not now. The sound is gone.
The clinic has come home. Finally, families everywhere can enjoy the best remote primary care we all deserve. Smart Clinic by TytoCare.
So that's a very high level, very markety overview of what we do and what we aim to do. But really our goal is to make sure that anyone, anywhere has better access to primary care, whether that is in their home or whether that is leveraging community sites, which is kind of more what I'm going to speak about today. So let's just kind of take a quick look at what the problem is, right? So equitable healthcare in rural communities is tricky. I'm not talking about just good enough care. I'm not talking about better than nothing care. I'm talking about equitable in terms of, meaning available, high quality, sustainable. And I'm sure this is something that you're dealing with in many of your communities as well. And this is what we're really looking at Taito Care. There are so many challenges in providing this kind of care. 4.5 billion people lack access to essential healthcare services. And 50% of the world's population live in rural areas, but only 25% of clinicians live in rural areas. And this isn't, we work a lot with the United States, but we also have global partners, and this is the same no matter where you go. And this isn't just about geography, it's about equity, because, if there's care 3 hours down the road and you can't get there, then it's irrelevant that the care is there, right? The care needs to be somewhere that you can access it, someone that you can access it at with a reasonable time frame, and in a way that does not disrupt your life to the point that you're then unable to benefit from it. So let's just take a look at the realities on the ground. And these are things, as I mentioned, we do work a lot in the US, but we also work with partners in Africa, in Europe, in Asia, in South America. And these really are some of the challenges that we're seeing across the world. So long travel distances, hours of travel just to reach a clinic, no local doctors. And again, we're looking at that kind of 50% of the population versus 25% of the clinical staff. Whether even those who can access a clinician in their area might have to wait for a long time to see them, just because of the population being significantly more than the number of clinicians available. And of course, all of this is leading to delays in diagnosis. So you're looking at worsening conditions, worse outcomes. In some areas, even a simple sore throat or a cough becomes a crisis because there's just no way to check what's actually going on. Excuse me, my kids have just come home and they're screaming. I'm just going to close my door. There we go. And then, of course, something that is, again, common across many of these rural locations is connectivity issues. And so when you might be looking at telehealth in regular circumstances that can solve problems in those places that do have better connectivity, there are many, many places that don't have that connectivity, that you can't just say, all right, get on your phone, do a FaceTime with a doctor, because people could be sitting in their houses and not having internet connection. But from our perspective, that's where virtual care comes in, and that's where these kind of community clinics come in. So this, for example, this picture is actually taken from a video put together by a partner of ours, and they work with local communities in very, very remote areas, leveraging the clinics and leveraging the clinic's infrastructure, so that people don't have to try and do a FaceTime where there's no internet. I'm going to get into that in a minute. And I'm sure that many of you in the communities that you're working in have experienced challenges like this. What I want to share today is how we're solving this at Taito Care, how AI comes into this, to try and make things a little bit easier and a little more scalable. So we believe at Taito, and I independently as well believe that healthcare should come to the patient, not the other way around. That's the best way to make things more manageable, the best way to give people the best access to care. And our mission really is simple. What we do is to replicate the in-clinic experience with remote physical exams. So that means that we can connect you with a clinician who can remotely listen to your lungs, listen to your heart, look in your ears and throat, and get live streams of those video feeds or sound feeds, also including a thermometer, can listen to abdomen sounds, and do skin exams as well. Which means that anyone who has a device, whether it's in their home or in a community clinic, can connect with a clinician who can not talk to them on the phone, which is very nice, but can actually examine them. which is better. Just a couple of words about our solution. As I mentioned, we have this handheld kit. You can see that here in the picture. We cover urgent care, primary care, and specialist care situations. We work with different providers, so it doesn't matter if the provider, works with a specific electronic or medical record platform or whatever that looks like, we can integrate into there. But what you can see along the top here is our Tyto Insights, and this is our AI-powered diagnostic support. And this is really key because everything that is going into Tyto Care is getting fed back into our Tyto Insights. And I'm gonna tell you a little bit more about that, but that's where our AI comes in, and it really is a layer that kind of powers everything else that we're doing. So as I mentioned, we are kind of working, one of the models that we work in is a home-based model, but the other one is leveraging different sites, and we kind of call them remote clinics or micro clinics. And we've designed it not just for convenience, which is nice when you have it in your house and you have internet access and you're sitting on your couch and your kid's sick in the middle of the night and you can take their temperature and connect to a doctor and look in their throat immediately, but also for real world constraints. So for those people who can't do that, talking about, low bandwidth or maybe, don't necessarily have access to a system that offers that kind of service. That's why we work with community health workers in rural areas. And they could be based in schools. They could be based in, urgent care clinics, community clinics in rural areas, senior care homes. We also work with visiting nurses, so partners of ours who are sending kind of less qualified clinicians out to people's houses, enabling them to connect with a doctor who's sitting in one remote location. So they've got, 10 teams, they don't need 10 doctors. They only need the one doctor who's sitting in a remote location and who can connect with all of the different teams. And just for some context, we have 1.6 million patients who are using our platform, and we work across over 25 different countries. And these are some of the logos of health organizations that we work with. And the reason I've kind of dived in here, and this is not attempting to give you a sales pitch, is just to kind of show you the scale to which we're enabling this, is really making a huge impact across all 1.6 million patients to their access to care. And some of these, some of the logos that you can see here are urban systems in America who maybe don't have those specific challenges. But some of the logos that you're seeing here are hospitals in South America who are, as I mentioned, providing care to very rural areas. And I've actually got a video here from one of our partners, M-Pharma. So M-Pharma is a company based in Africa, and they work across Ghana, Nigeria, Kenya, Zambia, Malawi, Rwanda, Ethiopia, Uganda, and Gabon. And their goal is really to improve access to medicines, and they provide financing and inventory management solutions to hospitals and pharmacies, with the goal of kind of lowering prices and improving access. Now, what they've done is they've set up Tyto Pro Smart Clinics in over 100 pharmacies that they work in. So I just want to play you this video because I think it really showcases increasing the access to care in those rural communities.
The sound is not working. Oh, let's see.
The multi-doctor setup has improved upon virtual consultations as we know it. As doctors, we're able to see our clients as they come in, which is a very important factor for every doctor. Every consultation begins as soon as the client walks in, and we assess them as they walk in.
Hey, Rwanda. Good morning.
How are you?
Fine.
To our patients as well, this has lent some confidence in the fact that they can see the exact doctor they're speaking to, they know your name, and they know your exact credentials as well.
Multi-doctor is not like your regular virtual doctor consult. We allow our doctors to leverage technology to do a number of basic tests on the patients remotely. They can perform tests like check the heartbeat, the lungs, can do a throat examination, can do an ear examination, they can check the temperature of the patient and be able to use this data to make informed medical decisions.
The absence of a physical doctor wasn't an issue, especially in the circumstances that we find ourselves in with COVID and restrictions.
Deep breath.
Also, see the pharmacy as using modern technology to assess healthcare for their benefit.
Our vision as M-Pharma is to develop an Africa that is in good health. And we want multi-doctor to be a service that allows patients and doctors, wherever they are, to be able to enjoy good quality healthcare.
Okay, so I hope the sound on that isn't amazing, but I hope it came through clearly to everyone. I think that really showcases how this kind of virtual care setup can really help in rural communities. So let's get into AI, okay? Why does AI matter in rural care? One of the challenges that virtual care, whether it's Taito Care virtual care or whether it's regular telehealth, has been suffering from is that no one trusts it. Why don't people trust it? Because they're connecting to like a random clinician that they've never seen before, they'll probably never see again. And they haven't necessarily had good experiences, right? I'm gonna call somebody on the phone and say my throat hurts, and they're gonna say, well, does it feel scratchy? Does it feel itchy? What happens when you cough? There's no connection here. And ironically, you'd think that AI would kind of take the human out of that and maybe make the connection harder to build. But the way that we're leveraging it is really to help build that trust back up again. So patients need to feel confident in the tools they're using. Clinicians need to feel confident in the data that they're receiving. And so what our AI is doing is guiding patients and supporting clinicians and making sure that the exam is usable and accurate. So our AI is really built on a proprietary data set. So every time that someone does an exam in a doctor's office with a stethoscope, that data is incredibly useful for the clinician for that visit. But then the data is done. What we're doing with Taito is we're recording that data, right? The whole thing is digital, so everything is recorded. What that means is, as opposed to that data kind of, being useful for that 5 minutes and then disappearing into the ether, all of those data points are saved. They are also saved cross-referenced. So something that Gabby and Shani mentioned was about bias. So what we're able to do is cross-reference all of our data with the patients who are doing those exams, so that we're kind of working on building on excluding biases from the word go, because we know if somebody is in a rural area or if somebody has a history of diabetes or whatever those factors are that could be affecting the results, or if they're a male or a female, etc. So what we've done is we've taken that proprietary data set, which we've been gathering for basically about 8 years now. And that consists of about 7 million data points, which is expanding around 33% a year. So it will continue to grow and it will continue to learn. And we've built FDA cleared algorithms for at the moment for lung sounds, but we have more coming down the road. And at the moment, the FDA approvals that we have, the FDA clearances that we have can detect wheezing, they can detect crackles, and they can detect rhonchi. So that's like our lung suite of algorithm detections. And our goal really, therefore, is to help the clinician. And what we've done is we've done studies around these, obviously. We're not just kind of hoping for the best. But we are seeing that our AI is detecting these lung sounds better than a regular primary care physician would. So we're working.
Excuse me, Joe, just for interrupting you, but you have maybe 2 minutes.
Okay, thank you for flagging. So let me just give you a really quick overview of how it was built. We take, as I mentioned, all of this data. It's all anonymous, of course. And then we have clinical specialists flag this. So whether they're pulmonologists, allergists, whatever the relevant specialty is, and they're reviewing all of this data and they're identifying abnormalities and pathologies, and then we're building algorithms that match their learnings. And let's just take a quick look at how this looks like in practice. So there's some futuristic elements in here, right? Because at the moment we're not connecting with things like wearable rings or Apple Health data, but our goal ultimately would be to do that. So let's take a look at Michelle. She's 45. She uses TytoCare for managing her asthma, and she was sleeping, and her wearable ring tracked that her respiratory rate changed while she was sleeping. She gets a notification to say, we think you should do a lung exam. And wheezes are detected. And until this point, the only human involved is Michelle, right? So everything is happening in the background, everything is happening with AI. But at this point, because wheezes have been detected, a clinician is notified. The clinician reviews everything and adjusts her medication. So these are things that can happen in rural areas, in remote areas, and they are also things that can happen crucially in areas and with communities who have lower access to clinicians. Because we're taking a lot of the measurements onto the AI as opposed to onto the human factor, that frees up the clinicians themselves to do the important part, right? Which is reviewing the data and saying, this is what Michelle needs, as opposed to measuring and coming back. And Michelle, did you check your, being the secretary for Michelle and making sure that she's tracking? Those are exactly the kinds of things that we can be using AI for.
Okay, thank you, Joe. I think that you're at the end. Do
Sure.
you want to close? Do you want to summarize?
But that was it. That was going to be my last screen.
Hey, you're amazing. Thank you so much. Thank you so much.
Thank you.
So in the interest of time, Shira has been, she would be following the chat anyway, but just checking to see, asking all of you to write in the chat so that we can maybe speed up in terms of questions. So
Yeah.
Shira, do you
Could
want
we
to
start?
speak?
Sure.
Sure.
Our first question from Catalina. Could you please comment on legal regulatory limitations for serving communities in other countries? I think Joe, this.
Yeah, so what I can say is our algorithms at the moment are FDA approved. So they are approved within the US, but not globally. That's something that we're working on. And then, of course, depending on where the health system is, obviously within the US, you're not going to be able to serve across state lines. Obviously, we're working with specific health organizations within each country. We don't provide the clinicians, so we work with the health systems who provide the clinicians so that we're always dealing with local teams.
So it's an open area, actually, one that needs some work, Catalina. Yes, sure, go ahead.
Okay, Jeanette. Jeanette had a question that was a little bit
Long.
longer. Um,
Sorry.
that's okay.
I'm happy to take it. I read it.
Okay,
Okay.
amazing. Perfect, Shani. Thank you.
So the use case of Oracle and Cerner is actually very, very new. I have a friend who is a product manager at Oracle and is just doing this integration right now. And I see that you are deploying in 170 healthcare systems, which is, I would say, one of the first use cases of improving and upgrading like EHR systems in the world, actually, because these EHR systems in America, they don't have any incentive to incorporate AI systems. They have like job security forever, and the switching costs are extremely high for hospitals, so they're very reluctant to do that. But I would say when you're implementing, there are a couple of things to keep in mind. One is to co-create and to start small with low risk. Yeah, I see in the chat that she says that it's the first of its kind. Yeah, it's extremely new. But co-create and start small. Like think about specific MVPs that you can generate in order to generate trust, and then transparency and adding that good friction. What I discussed in my talk is crucial here. You want to have the physicians understand why the AI chose one option over the other. And so the transparency and the reasoning is very important. And then, of course, I would say the clean data would be the biggest risk here with 170 sites, because of the data consistency will probably be pretty poor across a lot of these healthcare systems, and AI won't help if it's built on messy or incomplete, medical records. I would definitely address that first. Yeah, that's what some of my thoughts around it. And you ask if there is a clinical use case, not in that scale. It's pretty new.
Thank you,
Thank you
Shani.
so much. And now we have a question from Nayanjeet. Given quality health data are limited and potentially biased in many low and middle income settings, how can reliable AI models be developed and validated to ensure equitable outcomes, and how long will it take?
Just dive in.
I think that is, Gabby, you might even have more insight into this than I do.
Sure. So I think a length of time I would say is a harder one to predict. But I think, part of this conversation and why, this is such a great topic for this group of people is it's going to require, first of all, the data to come through, and us and pushing the agenda as well, like having people who are willing to put themselves out there and say, this is bias, this is not equitable, this is something that we need to improve, and gathering that data, bringing it to the table, figuring out ways to do that in some sort of systematic way. And I think, being part of the hard part here is when people get into in the innovation space, they get very excited about things that make money, and figuring out how to build systematic like data collection in some of these settings is not necessarily going to be profitable in the short term. I do think in the long term it can be, and so maybe figuring out a way to present, and this is something I do a lot, is figuring out how to connect clinical outcomes or areas of interest for healthcare improvement to business and economic outcomes, because ultimately that's what, unfortunately, people who have the money to invest, they, yes, care about things in the goodness of their heart, but it is hard if they can't see what the economic gain will be at the end of the day. And so it's I think up to this group, and maybe we can think about it together, we can start a dialogue here, how to try to bridge that gap and show the world that this is something that can be profitable, and that should get a lot of investment. But I think that's really what it is. It's an investment of resources and time, and
And all of you said put humanity at the front end.
Do we have time for one more? We have 1 minute,
We
so we
do.
might need.
Yes.
We have time. Okay, from Heinstein Zamir. References for title sensitivity and specificity.
Yeah, if you drop me an email after that, I can send them over to you with pleasure.
Okay, then I will close. Thank you all. All of our speakers, our panelists are on LinkedIn. And so, although they will share, we can indeed share. I think it's probably best through LinkedIn, right? Rather than through email. Uh, please check out there. And if you have any difficulties, come back to us, come back to Shara and or myself to make contact, to have questions and get answers. I want to thank you all for just a fantastic hour and a half more, and we could just go on and on. This I really know. So thank you so much for Gabby for opening it up in a way that I think that even I could follow into the next presentation, and Shani and Joanna for the real case study in rural areas, and Shani for doing a much deeper dive in. I'm learning. It's a language. I'm learning a language. There are people on this call, in this room, or in this Zoom, who have this language down pat, but it's not me. But there many are. So I thank you all for joining us. The June the 15th will be our next webinar, and it will be Mashab sponsored. The information for that will be we sent out to WhatsApp groups and to Shira has kept, of course, a participants email list as you've all registered. And when we have the specific information of who is presenting, and we have sort of the topic, but more information, you would need more information to be interested, we think. We'll send that to you via your registered email. So thank you so much, all of you, for participating, for joining us today, especially Gabby, Shani, and Joanna. Shira, absolutely, for all of your work on the coordination side, and have a very good month, I guess it is. Here we go. Thank you all. All the very
Thank
best to
you.
everybody.
Yeah.
Bye
Thank
for
you.
now.
Bye.
Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye, everybody.
Bye.
Hi, thanks, Jeanette, for joining from the
Bye.
States.
Thank you.
Catalina from Miami.
Bye-bye. Bye-bye, Maureen. Bye-bye, everybody.
Bye-bye. Who's that?
Bye, everyone. Love and kisses.
That's Sheldon.
Bye.
It's Sheldon from Nigeria.
Oh, okay.
Maureen.
Lovely. Nice to hear you.
Nice to hear you, Maureen. All right. Have a wonderful week.
You as well. Thank you so very much.
Bye, Maureen. Dennis from
Bye,
Nigeria.
Dennis.
Yeah.
Thanks for joining. Dolph,
Bye,
thanks for
Maureen.
joining.
Bye, Maureen.
Bye, Martin. Bye, Thandor. Bye, Shagan. Okay, I'm
Yeah,
going to
bye-bye.
close it now. This is the long goodbye. This is the goodbye. Thank you, students, so much for joining.